Okay, it is 2 minutes past the hour, so I will go ahead and get started and introduce our speaker for today. I am Leslie Appiah, and I am the chair of the Female Oncofertility Scientific Committee, and there are many members of the committee on this call. So to introduce our speaker, Professor Frédéric Amant is currently professor at the Catholic University of Leuven, Belgium, and University of Amsterdam, the Netherlands, where he heads the Department of Gynecologic Oncology of the Netherlands Cancer Institute and the Amsterdam University Medical Centers. Professor Amant co-founded the European Network for Individualized Treatment of Endometrial Cancer, a task force within the European Society of Gynecologic Oncology, and founded and heads the International Network on Cancer, Infertility, and Pregnancy. He is recognized as a world authority on cancer and pregnancy. We are lucky to have him as a member of the Female Oncofertility Scientific Committee of the Oncofertility Consortium. The title of his presentation today is Effect of Immunotherapy on Fertility. Without delay, Dr. Amant. You are muted. You are muted.
This is better, I think.
Correct.
You hear me now?
We do.
Okay. Thank you, Leslie, for this kind and extensive introduction. Welcome, everybody. It's a pleasure, but also an honor to be part of this wonderful team, and happy that the proposal to share with you our thoughts on immunotherapy and reproduction were retained, and that we established like some slides to give you an update of where we stand in this regard.
Dr. Amant, may I interrupt you for 1 second?
Yes.
We are seeing your entire slides with your notes. Are you able to do screen share where you just have the presentation view, presenter's view?
Okay, I've got,
your notes.
So what do you see?
We see the slide with your notes at the bottom as opposed to just the slide. Mm-hmm.
Okay. In my view, it is just 1 moment. This is not better.
That is not better, correct.
No.
What about if you go to the top left where there's a little slide, keep going up a little bit and to your right? What is that button? Can you click on that and see what options we get?
No, this is not. Is this
Maybe
better?
Exit. No. Maybe exit out and try again. Like exit out of this view. Or escape, I should say.
I will just. Okay. Just 1 moment. I will just go and look for it again. That will be better.
That is better. Thank you.
Yes. Okay. Thank you, because I didn't see it. So, I can, after this session, I think this is my take-home message I'd like to retain. I want to show you that cancer treatment, including chemotherapy, is possible during pregnancy. And when we focus on immunotherapy, there is good evidence that immunotherapy during pregnancy impairs the placentation and fetal growth, and that we should be careful because of side effects that can also occur in the neonate. If we look into the literature and focus on infertility, it appears to be less common, but mainly there are many unresolved questions and actually too much to draw firm conclusions. This is a bit the agenda. I want to introduce you on cancer treatment during pregnancy, focus on the long-term outcome, then immunotherapy, pregnancy, and fertility, and just in general to underscore the importance of a multidisciplinary setting, and a new project that we established, launched, the advisory board. And giving you an introduction on the theme of cancer during pregnancy. In fact, in countries where we have like a complete registration, we see that malignant melanoma is in fact the most common cancer. But due to the fact that this is not always treated actually in hospitals, and this is what we see at the right. You see my cursor, huh, Leslie?
Yes.
The most common cancer in hospitals basically is in fact breast cancer, followed by cervical cancer, lymphoma, and ovarian cancer. Overall, we see that the stage at diagnosis is in fact later when compared to non-pregnant women because of pregnancy symptoms that may mask cancer symptoms. And here I want to give you just a flavor of what we can or what we deal with in the clinic. This patient was actually treated for a mastitis, treated with antibiotics, but it did not work. And at that stage, at 33 weeks of gestational age, she was referred. As oncologists, we did not think on mastitis, but were indeed our suspicion was confirmed. And this patient had a grade 3 invasive ductal adenocarcinoma. This patient was staged. There were no metastasis, and she was treated with chemotherapy during pregnancy, delivered, and continued treatment afterwards. This is another patient. She was referred from the south of Belgium, the French-speaking part, at a gestational age of 18 weeks, also with a suspect mass in the breast. But unfortunately, on imaging, and maybe we can focus on the scan at the right, we see not only axillary lymph nodes in the green arrows, but also bone metastasis and multifocal liver metastasis. This patient actually preferred not to continue the pregnancy, and this pregnancy was aborted. So this is just a flavor of what we deal with in the clinic and the spectrum, basically. If we focus on cancer during pregnancy and its treatment, whether the treatment is possible or not largely depends on the trimester. As you can see, we see the chemotherapy is actually not used during the first trimester, but it can be used during the second and the third trimester. For radiotherapy, it is actually the opposite, and I will tell you why. Breast surgery can be done through the whole pregnancy, including a radioactive use of for the sentinel lymph node biopsy. But radiotherapy of later in pregnancy or targeted treatment, endocrine treatment, is actually not advocated during pregnancy. And during the following slides, we will go deeper into these different options. This shows that we can operate during pregnancy. In fact, we have a lot of experience with surgery in pregnant women, mainly because we operate a lot of non-oncological conditions during pregnancy. And what is important, key, is to take care for the mother. And if you take care for the mother, you will take care for the baby, and the baby will be fine. For obstetricians, it is always the discussion, should we monitor the fetus or not? Well, that depends on the fetal viability. If the fetus is viable enough, as we see at the right, we do the monitoring, because in case the baby is doing bad, well, we would react and we would do an emergency cesarean section, which until now, in my experience, or what I heard, was never needed. This is also a patient with cervical cancer, and you see that after a certain gestational age, actually 20 weeks, that the patient is put in a left lateral tilt position, allowing the cardiac preload to sustain and not to compromise actually the cardiovascular system. So, but in these conditions, we can definitely operate patients. And this is an example of a patient that presented actually in the beginning of the second trimester with an ovarian mass. We see the fetus, and we see also actually a good vascularization, which was of course a suspect observation. at MRI tumoral mass of the left nexa, which was sharply delineated and there was no invasion. So we decided to operate. And here we see actually the mass. This is the pregnant uterus. It appeared to be so we did actually unilateral salpingo oophorectomy, complete peritoneal staging, also the omentectomy. It appeared to be a stage 1, grade 1 dysgerminoma, which is which only occurs actually in young women, and for which actually no further treatment was needed. So she was completely treated during pregnancy. With regard to radiotherapy, in fact, the main message is that the distance between the fetus and the field of irradiation is important. We should make sure that the threshold for fetal toxicity should not be exceeded. And this is mainly the case so early in pregnancy, the first trimester, and maybe the beginning of the second trimester, but it depends also on the organ. So mainly head, lymphoma, or breast, thyroid gland, these organs can be irradiated. And here is an example of a patient with actually a small cancer, was operated. She did not need chemotherapy. That's why we completed her treatment during pregnancy with radiotherapy during the second trimester of pregnancy. This is a physicist who actually calculated, who told us, listen, for this patient, for this cancer, and for this gestational age, the fetal exposure is below the threshold. So he was also involved in installing the patient with LED screens in order to protect the fetus even more. But there will be always some scattering from inside the body to the fetus. So you can never actually decrease the fetal exposure till 0. Also, chemotherapy is possible. Basically, the whole idea is to maintain dose intensity as in non-pregnant women and to use standardized protocols. These standardized protocols are there because they offer the best options, best prognosis for patients. So we need the same protocols. We should not deviate from the standard protocols. And we need to use the actual body weight of the patient and not take the body weight from once and then during the several weeks and months use that initial body weight, because it changes, of course, in pregnant women. There's also no need to increase the dose, and we recommend to continue the chemotherapy till approximately 35 to 37 weeks of gestation, allowing the body to recover for a safe delivery. With regard to the children, this is in fact very important because the whether or not we can treat largely depends on whether the outcome of children is normal or not. We have recent update of our registry in more than 700 children. We could see that actually after 12 weeks, there are no more or other congenital malformations. But before that, the chance of a malformation is not 100%, but there is definitely an increase in congenital malformations. You see the blue dotted line is actually the 7%, which is what you would expect in a normal population. So the message here is after 12 weeks, chemotherapy does not lead to more or other congenital malformations. The paper in 2015, we investigated 129 children at a gestational age of 18 months till 30 months. And we did do the Bailey scale of infant development. And as you can see from the curve, there was no difference between controlled children and with children during the pregnancy exposed to chemotherapy. We updated that series, we followed it, and this is a study done recently when the children were 6 years old. Important is that the full-scale IQ was normal, but the verbal IQ was actually lower in children exposed to chemotherapy, but the performance IQ and the processing speed were in fact normal. Even more important, the verbal IQ was here only 6 points in general, but when the mother died, it was 15 points lower. So the hypothesis is that, in fact, chemotherapy itself has no direct effect on the fetus and its development, but rather the poor condition of the mother and the difficult situation for the family with less attention to the child led to a lower verbal IQ. So this is an important message also for the children. But overall, if you look to these children, they actually do normal, independent or irrespective of the type of chemotherapy, the number of cycles, and so on. So definitely no reason to abort or to terminate a pregnancy. All these children actually were exposed to chemotherapy during pregnancy. Focus for today also is the immunotherapy and pregnancy, because to a large extent, immunotherapy has changed completely the oncological field. This is a patient with a melanoma, just from the literature. Let's say 10 years ago, this patient you see at the left would only survive with a median of 3 months. Now we see with immunotherapy a complete clearance of all this disease, and we really have like long-term survivors with immunotherapy. And that results in the fact that also in our clinic, and when we treat pregnant women, we have this question. For example, this is a patient from the Netherlands, 20 years old, first pregnancy, 28-week pregnant, and she presents with actually axillary, lymph nodes, liver metastasis, bone metastasis, for which in fact immunotherapy was needed. But in the absence of data, the question we received is, well, what would you do with this patient? And what we would do, I want to summarize in the next sessions. Also, because of the complete lack of data, or well, not complete lack, but in the absence of a review, we decided and we proposed Lancet's group to write a review on this, and that was published in December last year with an international interdisciplinary group. The basics of immunotherapy is that cancer cells, in fact, evade the immune system, and there are various mechanisms of immune tolerance, because basically the immune system is strong enough to fight against the cancer cells, but the cancer cells are actually very intelligent. And therefore, we are constructing different kinds of immunotherapeutic drugs using different modus operandi to circumvent this immune escape mechanism of the cancers. So the central mechanism is that these immunotherapies stimulate the natural immune system to recognize and destroy the tumor. Overall, we can say there are 5 large groups of cancers, and the most important one are the checkpoint inhibitors that prevent tumor from turning off cancer-fighting cells. And in fact, today, they are actually used in a wide range of diseases that are depicted here. Also important is cell treatment, cell therapy, where actually immune cells are removed from the body. They are genetically modified, expanded, and infused again in the patients. So the own immune cells become cancer treatment drugs. And this is the so-called and quite famous and very expensive chimeric antigen receptor T therapy for leukemia and lymphoma. Also used are cytokines that in fact boost the T-cell compartment and the body's immune system in general. This is for advanced melanomas and kidney cancer. We have vaccines that teaches the body to recognize the cancer. We will not see this in our patients. And we have oncolytic virus therapy, which is used for advanced melanoma. We will mainly focus on the PD-1 and the PD-L1 because, as you can see from this slide, the clinical trials, the approval of drugs is mainly actually for PD-1 and PD-L1. Together, they constitute 65% of all the studies and approvals for the use. So just a short introduction on the background of this immune checkpoint inhibition. And what you can see at the left is actually the PD-L1, PD-1 is actually part of a physiologic system that helps to moderate the immune response, making sure that the immune response is in fact not too severe and not too long. So it's like a homeostasis, physiological homeostasis in our body. The problem in cancer is that the expression of the ligand and of the receptor actually, in tumor cells and in T cells and in the microenvironment is in fact actually such high that the T cell cannot exert its function anymore. So the normal physiological function of the T cell compartment is inhibited by too large expression of this PD-1 and PD-L1. So what these drugs then basically do is they break this connection, allowing the T cell to do its function, why its function leading to a destruction of the cancer cells. So this is the basic principle from this new immunotherapy. But today we also talk about a special situation because we talk about pregnant women. And here the immune system is also altered. This is mainly altered in a moderated state because from one side, it needs to be tolerant because the fetus contains paternal antigens. We call this the semi-allogenic fetus. And so the mother should not, or the immune system should not attack this fetus. Apart from that, the immune system needs to maintain its ability to protect against infections and toxins. And overall, there are three phases, which is the first phase is during early pregnancy, a pro-inflammatory phase that after the conception allows the implantation and the growth of the embryo and the placenta. The second and third trimester, it is an anti-inflammatory state, allowing further growth. But at the end of the pregnancy, it is again a pro-inflammatory state, allowing labor, delivery, expulsion of the placenta, but also the healing of the wound in the uterus. In fact, this feto-maternal interface is very important. And this is actually this board here. This is what we call the decidua, which consists of trophoblast, decidual stromal cells, and a whole set of immune cells, of which the natural killer cells are in fact most importantly present. And this system helps in the tolerance and is key for the regulation of this trophoblast invasion, the placental development, and this feto-maternal tolerance. But as you can see, and that's why it's important, all these cells also have receptors. And especially these receptors actually are the target of some of the immunotherapies. So if we use these drugs, it can interfere with this feto-maternal tolerance, maybe fetal growth, and so on. So this is the theoretical thought that we need to investigate further with cases and studies. And in the next slides, we will go shortly through the data we have. In animals, so we start with the immune checkpoint inhibitors as the most important group. We know that it is actually, the drug is in fact too large to diffuse passively to the fetus, so it needs receptors. But these receptors are called the Fc receptors, are not present during the first 14 weeks. So at that time, actually, these drugs can be used safely. Afterwards, there's actually a high transmission in the second and third trimester. And in the animal models, it has led to, or they have shown growth restriction, prematurity, and embryonal fetal and neonatal death. So confirming actually what we thought on a theoretical basis. But on the other hand, there was no direct embryotoxicity or teratogenicity in these animal studies. If we go to the clinic, only 7 reports were available. Patient 1 and patient 3 basically started their treatment during pregnancy. The others actually were pregnant when they, or took them drugs when they became pregnant. In rats is one case of a congenital malformation, which was a hypothyroiditis that resolved after 6 months. But important, 4 out of the 7 children that were born actually developed intrauterine growth restriction, placental insufficiency, or a combination thereof. So underscoring and confirming what we thought on a theoretical basis and what we saw in animal studies. But also important is that at the end of the day, the children were healthy, had normal or achieved normal development milestones, and there was actually no evidence of the cancer in these children. 6 out of the 7 actually mothers had melanoma. 1 mother had a trophoblastic disease. But there are also side effects. And the question is, should we not be careful for fetal immune-related adverse events? Because indeed, all these drugs actually can affect nearly all organs in our body. And most important there is the skin toxicity. Up till 45% of patients receiving these immune checkpoint inhibitors will show some toxicity, but also the thyroid gland can be involved, the liver, gastrointestinal toxicity, or even lungs can be affected. In fact, probably the one child with an hypothyroiditis, probably this is already a kind of an affection of the fetus. We also were confronted in the Netherlands with a child that developed a nearly deadly type of enteritis. And as far as we discussed with the physicians, actually, we were severely thinking that this must be like a complication or a side effect of immunotherapy during pregnancy that only started a few weeks after the delivery. So we should definitely take care that these toxicities can also occur in the fetus. But the side effects can be severe, and when they are severe, they can be treated, and then they are treated with high-dose steroids. And we know that also these steroids can go to the fetus, and that gestational effects like gestational diabetes or fetal oral facial clefts, especially when after the first trimester exposure can occur. But of course, also the fetal hypothalamic pituitary adrenal axis function can be impaired. So we should also take this treatment into consideration when we want to evaluate and assess the fetal danger. This for immune checkpoint inhibitors, the cytokines. Basically, interferon alpha is actually considered safe, mainly used for hematological cancers. Interleukin-2, in fact, can lead to severe toxic reactions. And in fact, we believe that we should only use this when the possible effects outweigh, maternal effects outweigh the negative effects on the child. Cancer vaccines, basically, live vaccines are generally contraindicated, especially in pregnant women. We believe we may make one exception, which is the use of the BCG vaccine, but only intravesically used. The TVAC, which is also like an engineering of herpes simplex virus, we would not use because wild-type infections in adults or in the mother can occur. And of course, this is something we don't want, an herpes simplex virus infection in a mother, because also the fetus there can be infected. So also this one we should avoid. Other immunomodulatory drugs include lenalidomide and pomalidomide. In fact, they are derivatives of the famous thalidomide of the Softenon drama. So they interfere with the angiogenesis and they are therefore absolutely contraindicated. Actually, there are virtually no data on the adoptive self-treatment and bispecific T-cell engagers. And for this reason, we would not advocate its use during pregnancy. When we talk about immunotherapy and fertility, I should not explain this audience that the hypothalamo-pituitary gonadal axis is crucial for a normal fertility. But maybe the bad news is that in fact, these are endocrine organs. And then we know, if we look to the long-term implications of immune checkpoint toxicity, that mainly the joints and the endocrine organs are affected. And basically 40% of patients has some of these long-term toxicities. But maybe even the number of, for example, what we see here, the chance that adults develop an hypophysitis is about 5 to 10%. Most commonly involved organ is a thyroid gland, and mostly after a period of a thyrotoxic storm, actually there is a period of frequently permanent hypothyroidism. This is what you see in this slide. It's actually a great review, and this score is 80 to 100%. So the chance that if you have a hypophysitis or thyroiditis, the chance that it is permanent is actually quite high. So this is, from theoretical point of view, bad news. Now let's go and to see two studies. Basically, in non-human primate model studies, there is no sign of carcinogenicity or gonadotoxicity in very high doses, so 6 times higher dose than normally used. There was absence of newly formed corporal lutea and reversible irregular menstrual cycles. But as we see here, 5 patients were able to conceive during this treatment, and even 1 patient, after a period of 10 years of infertility, conceived after its use. So maybe it is, from this point of view, not so bad. Garuti and colleagues for us recently reviewed this whole team, and they looked, or they distinguished primary hypogonadism, so the primary toxicity on the testis reducing to less spermatozoa or poorer quality, or to the ovary with poor quality oocytes. And indeed, ICIs can cause primary hypogonadism, but especially in men, there are no data in women. And in fact, if we then look to men, there's complete uncertainty about the frequency of this adverse effect, the magnitude, the duration, and actually the implications on fertility. They also look to cases of secondary hypogonadism. So that's when primary, the hypothalamo-pituitary axis is involved. And also here, this is like a well-known side effect, but only in maximum 10% of cases. But all the data actually show that there is an effect, but there is complete lack of knowledge on the frequency, the magnitude, and what, at the end of the day, the effect is on fertility. So if we take everything together, there is actually a weak association with hypogonadism. It is rather rare, or maybe the literature has insufficient attention. The Nature review, actually the word fertility or hypogonadism is not mentioned, never. So what I say is like an extraction of the information. But so from that study review, we can believe that maybe in the clinic, it is not so much of a problem. Actually, the studies are not designed to show actually or to make the difference between primary or secondary hypogonadism. And indeed, women are less likely to be involved in this matter. A few words on the importance of a multidisciplinary setting. When we started the study, actually perinatologists were never asked to be part of the team. So we really believe that they should be part of the team and basically defend the fetal rights, because it were always the oncologist, and they really look at it from an oncological point of view. So we advocate really that also the fetus should be, let's say, defended or represented. We also showed that we clearly saw a trend towards increased cancer treatment, and especially chemotherapy. But this use of chemotherapy is associated with small for gestational age babies and admission on the neonatal care unit. So also here, we can treat the patients, but obstetrical high care units should be available and prepared and experienced to deal with this. This is a patient where also this multidisciplinary setting is to show actually in practice its importance. As you can see at the left, this patient had a corporeal incision for cervical cancer. She had actually pelvic lymph nodes, and for oncologists, it is then important to stage the patient to know whether the parotic nodes are involved, allowing to tailor the field of irradiation. So you can only do that if there is a clear and a good collaboration discussion among all involved specialties. Last but not least, I want to introduce you a new project that we launched May last year, the APSIP, the Advisory Board Cancer, Infertility and Pregnancy. And the background is that many of us received like a personal advice for a request for an advice. We all do our best to provide and to share our experience as good as possible. But nevertheless, we thought, this can be better. I am not a hematologist. I cannot go into detail on this kind of treatments, for example. So we decided to set up this board of experts where you actually, everybody for free, you can just easily click on the link, introduce actually your question. This is like an example of last week. So today there are actually 4 advices that we are elaborating on. You as a physician, you can identify yourself, but it's not obligatory. You introduce the key clinical characteristics, and then you actually describe your concrete questions for this particular patients. And then we, from the other side, we all give our advice. We establish a letter, and our aim is to write you within 1 week a proper multidisciplinary international advice. And you see, this is a patient. Actually, the first two patients actually are patients with questions regarding the fertility. These are patients with cancer during pregnancy. The whole idea is, and this is also an invitation for you at wherever you are, it is not our aim to deal with all the questions. And we hope to establish like national or regional boards. And this is what I want to say with this national APSIP, and that this system functions without our involvement, and then maybe for exceptional cases or for physicians that cannot rely on this national or regional board, that they directly contact the International Advisory Board. So coming back to my take-home message, I hope that I could show you that cancer treatment during pregnancy is possible, including chemotherapy, that immunotherapy, in fact, from theoretical point of view, but also in the clinic, we see that this impairs placentation of fetal growth, and that we should also take care about side effects that not only can occur in the treated mother, but can also occur in the fetus. About immunotherapy and fertility, from the literature, it seems not to be so much of an issue, but we have to say that it is poorly documented and many unresolved questions remain. I need to thank all the sponsors that pay for the studies we do. Very proud of the research group that helps us to establish some of the presented data. We thank our patients and children that do a lot of effort to visit our centers to be investigated. And with this slide, I want to thank you and happy to tackle questions or discuss further.
Thank you so much, Dr. Amant. You may place your questions into the chat and I will read them, or if you would like to ask them directly, you may unmute yourself. I have a question, and I know, as you stated, there isn't much data on the immunotherapies and fertility. I think, though, I've read some contradictory information on bevacizumab and Avastin and ovarian recovery. Is there any real data on that? Have I made that up somehow? I think that the data I've seen is maybe 30% may not have ovarian recovery, but is that not actually true? It's a monoclonal
Well, that's a good
antibody.
question. That's a good question. I think that is really difficult to really answer because patients do not receive bevacizumab on their own. They always receive bevacizumab in combination with cytotoxic drugs, okay, and frequently with combination of drugs. Then they use the bevacizumab either together with the drugs, and then sometimes with up till 2 years after stopping the chemotherapy. So I think it is I'm not aware of any direct effect of bevacizumab. Of course, it decreases the angiogenesis, maybe blood flow, but never on such a way that I think it can impact the fertility. But again, I think it's very difficult to disentangle the effects of the chemotherapy, bevacizumab, and we also have to take the age into consideration, the number of cytotoxic drugs, the type of cytotoxic drugs. So from my perspective, it's still difficult to evaluate this.
Okay, thank you.
I have a question, Frédéric. Pasquale here.
Hello, Pasquale.
First of all, congratulations for a really very, very nice talk. I enjoyed it, every single slide. Thank you. I have two quick questions. One, do you have any information about children that have been now born after this new immunotherapy protocol given in pregnancy on their fertility, onset of puberty, if it's in time or not time? I mean, do we have any information?
No.
Or is it
as far as I know, I think actually this field is too recent. It only started recently. The children are not old enough. We have no hard data after chemotherapy, but there we see in the first glance we are we plan this analysis, but we don't have sufficient numbers to really investigate this. But from the children that we see, we're talking with mothers, actually there is no change in the menarche, in the development of the secondary sexual characteristics. So there is actually no aberration in this development. But children, adolescents are not old enough to really conceive, but from a first sight, it does not seem to be a problem. But
and the second question was related to the mode of delivery, the impact of, for example, you said the radiotherapy can be okay in the beginning, but at some point you start to mention potential issues with the placenta. And I want to know if there is a relationship between this type of treatment in pregnancy and then the mode of delivery is going to be, for example, cesarean section because the contractions are not optimal, and second, any specific pathology of these placentas. Thank you.
The reason why I showed, or the figure I showed, was actually a patient with cervical cancer during pregnancy, and this is particularly difficult because the pregnant organ itself is involved. And there are data in the literature that if the fetus is born through a vaginal route when the cervical cancer is in situ, that in many cases an episiotomy is applied, and this is actually has everything to allow cancer cells that come along with the child actually can implant, because it's a lot of blood, it is warm, so this is the ideal infrastructure for cancer cells to implant, and cases have been described of fatal recurrences in the episiotomy site. So that is the main reason, or that is the main maternal reason why we would not advocate this. But there's also a second reason, and the second reason is that actually in New England, January last year, there's a fabulous case report described of 2 children that basically developed themselves lung cancer, and it was shown, and that's why it reached New England, that these cancer cells originated from the mother. So that's also a fetal reason why we should do always a cesarean section in these cases. And then when the cancer is a bit larger, we prefer a corporal incision, because what also has been described is abdominal wound metastasis after cesarean section with a lower transverse incision. The hypothesis there, no hard data again, but the hypothesis is that if the cancer is large and the lower transverse incision is close to the cancer, that this may result in an implantation into the abdominal wound. So that's why in these cases we don't allow for a vaginal delivery and we prefer a corporeal incision. So cervical cancer and vulva and vaginal cancer, they are a bit the most important reasons to choose for an elective cesarean section. And apart from that, we have no impression that chemotherapy as such actually involves labor or the quality of the uterine contractions. And we use actually obstetrical indications to decide or not for a cesarean section or not. And with regard to the immune checkpoint inhibitors, I think from the literature, it is not really the contractions that we believe that are affected. And also the placental function can be involved, but that's not necessarily a reason to do a cesarean section. If the placental function is only a bit decreased, you can still allow, if monitoring is okay, a vaginal delivery. Of course, if you would continue and despite actually poor growth and poor placentation and poor placental function, of course, then that could lead to problems. From chemotherapy, we know that it affects the fetal growth. And I recall a case where we needed to choose for the mother. So we continue with chemotherapy, but we saw the growth curve of the fetus lowering and the fetus died in utero. So we should be very careful, and we should definitely in these circumstances make a balance between maternal and fetal benefits. We still had maybe one case, Leslie, that we could also, I'm not sure if there is still time.
Yes, there's time. Michel has a question comment.
Okay.
He's stating that the APSIP forum looks like a very interesting idea and is asking how many experts are involved in responding to the clinical case discussions. So your board.
Yeah, well, that's an that can vary from I would say 3 till, let's say, 10. Not all experts are questioning, putting an advice on each question. So it depends a bit. And sometimes, for example, for hematological cancers, we only have, like, for example, 2 specialists. So when we have their opinion, we are already glad we have their opinion together with our view, our approach. And then mostly we have sufficient stuff, material to put an advice. In total, we have like 20 experts in the international group. We have 10 in the Belgian group. We have 30 in the Dutch group. But again, not everybody is always responding. But overall, we are quite happy at this stage. We nearly formulated 50 international advices. The Dutch group started a bit earlier. In 2012, they formulated more than 100 advices. And overall, the physicians are actually quite happy. We are also doing a part of the study that we request after 6 months whether they followed the advice or not and why. So that could also give us an idea on how we can improve and what are reasons that why clinicians did not follow the advice.
Excellent. Okay, yes, why don't you do the last case, and those who can stay on will stay on.
So this was like a challenging case that we treated in April 2019 in Amsterdam. The case was particularly difficult because the patient had a preterm twin delivery at 26 weeks in her history. And now she presented with again a cervical cancer at 14 weeks. And again, this was like a monochorial twin pregnancy. We see here the in speculo examination. We see the twin pregnancy, and we see the cancer, which is very involving the whole cervix. This patient was very motivated to keep the pregnancy because we told her also, well, this is quite experimental. We have no experience here. We have experience in other pregnancies, but not with that history and only with single pregnancies. But she was motivated, so we did do an extraperitoneal lymphadenectomy to identify whether the patient was high risk or not. And so this is the extraperitoneal approach at the left, and we see the left pelvic side wall. Nodes were negative, so we decided to treat with chemotherapy. Again, this is the tumor, and here we see actually, or we can observe how the tumor after 3 cycles of Taxol carboplatin has changed actually, and definitely did not increase. We continued until 5 cycles, and nearly 35 weeks we did do a cesarean section. So this, well, I think it shows actually the difficult situations, but despite that it's difficult, that one can be successful and treat both mother and child at the same time. So this is, we thought that this might be a good case to further elaborate on questions and discussions.
Thank you. Okay. All right. I am not seeing
sharing.
any. Yep. I'm not seeing any additional questions. So I think that we are at the end of our time in our talk. Dr. Amant, thank you very much for that informative presentation. And for those of you who are still on, this will be placed onto the Oncofertility Consortium website, so you may listen to it at a future date. We will need about 72 hours to get it posted, but it will be there. Okay, thank you all for your time.
Thank you. A nice evening or day, all of you. Bye-bye.
All right.
Thanks a lot, Frédéric, for the fantastic talk.
Thanks a lot.
I think Yeah, I think few people in the world have this extraordinary experience in the topic.
Yeah, that's right. That's right. And Frédéric, yeah, I would personally like to know more about the board. I think we've wanted to do something like that here in the US through the Oncofertility Consortium, or at least the pediatric network has wanted to, but we haven't been able to launch it or make it effective. And if this is already established and it just means like learning how you do things and implementing it, I think that would be great.
So Leslie, be my guest. This tool has been established, and actually we can add you. Huh? We can have, like I showed you the slide with international and then regional or national groups. We can make of your consortium one group, and then you can promote your group among your network, and you're in charge of that. So we don't interfere. You can work independently using our tool. And if there's any other question or difficult situation, as I said, you can go to the international group. So we are talking with the Nordic countries, so Iceland, Sweden, Norway, Denmark, and Finland. We already are in place of making Iberico Hispanico, so that means Spain and all Spanish-speaking South American countries. We are talking with Oceania, so that means New Zealand and Australia. So they are interested to do so. Also Eastern Europe, because not all countries are large enough or do have all the experts. So then we merge them. So be my guest. Actually, the tool is designed to do this and to allow people to use it independently from us. So basically what you have to do is to identify experts to know the system, but once you need like an introduction, of course, to the system, but then it works very easy. There are no emails anymore. Everybody does it online. You see all the advices of your colleagues on this case, and then of course someone has to establish the letter, and that letter goes to the requesting physician. So yeah, and we are a bit fine-tuning it, but I think most of the fine-tuning work has been done.
Mahmoud, we should talk about how that would look. Maybe he or I could be a honorary member on your board to kind of sit in and see how the process goes.
Yes, excellent.
Yeah. Okay.
Yeah, because it's a different idea than the telehealth or telemedicine, because the network connects just the doctors, the referring doctors, and the expert, right? In a written text, right?
Yeah.
Right. Yeah, exactly. So because it could be a very good idea. Yeah.
Right.
Because
and I think
we are thinking in the direction of telehealth, Leslie, because now because of COVID and so on, but this is something different that connecting referring physicians on a very professional level.
Yeah, and I think it's a great idea that you have it online because people get email fatigue and they don't want the emails to come through. But if it's online and you get a message saying that there's a consult and then you go online and handle it, that makes it so much nicer.
Exactly. That's exactly what it is.
Yeah.
We can, I think, Leslie, we can make you honorary member, and maybe we can have a meeting where we go a bit more into detail to you and Mahmoud and others who are interested to share with you some more insight, because now I only used 3 slides as an introduction, but we can expand this, and we would love to do that.
That'd be great. Excellent.
The experience in this particular field, cancer with pregnancy, is really very rare, very, very rare. So to have a platform like this, it is a gift from you and your colleagues to help others. Really, I remember when we had this case, pregnant lady in 17th week of gestation, with suddenly diagnosed with acute lymphocytic leukemia during the pregnancy. We couldn't know what to do,
Well, we must say that because leukemia is one of the rare urgencies. So if we see this, we really decide to email our hematologist to say, listen, we need this in 2 days. And then, because normally we don't do that for every case. In normal cases, we say, okay, allow us 1 week. But for leukemia, we know this is urgent and we will not let you wait for 1 week. So we decide, we try to provide you with an answer as soon as possible, 1 or 2 days.
Yeah.
Excellent.
Very helpful, very helpful.
Thank you. Okay, well, we will see you. I'll see you in 4 weeks for the last webinar before the conference. All right, thanks.
Okay.
Talk to you later.
Talk to you later.
Thank you, everybody. Bye-bye.